I'll be talking about metastatic castrate-resistant prostate cancer, which is quite a challenge to cover in 15 minutes. So certainly that's my challenge to do today. As you can see here on this slide, the treatment landscape for metastatic CRPC has changed dramatically from 2004, when docetaxel used to be the main standard of care. And we now have a range of options available for men with metastatic CRPC, which has actually doubled survival. And for today, I'll be mainly focusing on treatments approved in the UK. So back to the definition of castrate resistance, which Ash has covered in his talk before. This is in the context of somebody on androgen deprivation therapy showing evidence of disease progression. This can either be rise in PSA or progression of existing metastases or new metastases with castrate levels of testosterone. And I've taken 50 in this slide, but as Ash mentioned, the EAU guidelines go with 20. And for today, I'll be focusing mainly on metastatic castrate-resistant disease. So what are some of the treatment challenges that we might face in clinic? I would say that this includes using the current drugs that we have effectively. We now have a range of options to treat men with metastatic CRPC. How do we sequence treatment to make sure that we are deriving maximum clinical benefit with each line of treatment? We know that patients are living longer. How do we maintain their quality of life? And also, particularly thinking about chemotherapy, how do we make sure that we do stop treatment when patients are no longer deriving clinical benefit? Longer term, again, that's been covered in talks before, the challenge is developing targeted therapies, finding new drugs and stratifying the care to the individual. And Shay has already talked about metastatic hormone-sensitive prostate cancer. And just to say on this slide that as we go further down the route, when patients become castrate-resistant, their treatment options will depend on what systemic treatment they've had before. For most patients, however, who haven't had these drugs in the metastatic hormone-sensitive setting, second-generation antiandrogens are the first-line preferred treatment option in the castrate-resistant setting. And I'll be talking about two main drugs, enzalutamide and abiraterone. So I know we've covered this before in Prab's and Ashwin's talk. Just very quickly, my diagram is a very simplified diagram of AR signaling pathway. And just to mention that abiraterone works more on androgen biosynthesis, whereas enzalutamide works more on the AR receptor and prevents it translocating to the nucleus as well. And I've summarized here the main trials looking at Abi and Enza. They were all phase 3 randomized controlled trials comparing Abi and Enza to placebo, both in the pre and post chemotherapy setting. And these have all shown statistically significant overall survival benefit of around 4 months. But there's been no trials comparing Abi and Enza head to head. So how do we decide which agent to choose when we see patients in clinic? And I think that boils down to the patient in front of you, their comorbidities and the toxicity profile of the drugs. So I've summarized here on this slide the main side effects that we see with Abi and Enza. Abiraterone causes high blood pressure, can affect liver function, and can also exacerbate cardiac disease, whereas enzalutamide causes more fatigue and subtle cognitive effects and carries a small risk of seizures, which is less than 1%. So, for example, if somebody had heart failure or poorly controlled type 2 diabetes, I would steer away from abiraterone, whereas if somebody had a particularly higher risk of seizures, for example, in the context of a recent stroke, maybe that would, I'll be wary of using enzalutamide. And how about quality of life? There is some published data around this, small cohort study of about 200 patients, which compared Abi and Enza pre-chemotherapy and in the real world setting. And the perceived cognitive function and fatigue did favor abiraterone at 3 months, which has been my own experience in clinic, I would say. But it does require a lot more monitoring. So typically when we see patients in clinic with abiraterone, we check their blood pressure, their liver function every couple of weeks for the first 3 months. And certainly in the context of the current pandemic, most clinicians, at least in our centre, have moved to using more enzalutamide, which requires much less monitoring. You can just give them an eight-week supply of treatment and they come back after 8 weeks. And there is also some published data around patients who show better PSA response at 4 weeks do better in terms of overall survival. And this goes back to the point which has been covered in previous talks about initially in the castrate resistant setting, most patients' disease continues to rely on AR signaling, and PSA is a downstream product of that. So patients' disease who continues to rely on AR signaling do better in terms of overall survival. So just in summary, with second generation antiandrogens, for the majority of our patients, this is the first line preferred treatment option. There are some situations where we might use early chemotherapy, which I'll come to. We don't use them sequentially in the UK, and actually there's increasing evidence that's not of any benefit. And as I've mentioned before, the choice of agent would depend on patient factors and the toxicity profile of the drugs. Moving on to chemotherapy, taxanes are the main chemotherapy agents that have shown survival benefit in castrate-resistant prostate cancer. And two main drugs I'll be talking about, docetaxel and cabazitaxel. So again, that's been covered in previous talks. Taxanes work on microtubules, leading to mitotic arrest and apoptosis. And TAX327 study was the main study showing a survival benefit with docetaxel. So it was a randomized phase 3 controlled trial with just over 1,000 patients, a 1-to-1-to-1 randomization between docetaxel, a 3-weekly dose schedule, a weekly dose schedule of docetaxel, and gentler weekly dose schedule, and mitoxantrone. And 3 weekly docetaxel came back as the winner, with a median overall survival benefit of about 4 months compared to mitoxantrone. The docetaxel groups did show an improvement in quality of life when you look at pain scores, etc., but at a higher risk of adverse events. So the common side effects that we'd see with docetaxel include myelosuppression, although the rate of febrile neutropenia wasn't high in this trial. Hair loss, sensory neuropathy, so those would be the common side effects we'd see with docetaxel. Based on this study, we'd go with a 3-weekly schedule alongside steroids up to 10 cycles. And the main evidence for Cabazi comes from the TROPIC study, which was again a phase 3 randomized controlled trial with a 1-to-1 randomization, cabazitaxel 25 milligrams per meter squared compared to mitoxantrone, and again showing a similar survival benefit of about 2.4 months. But the heme toxicity in this study was very high, so a grade 3 neutropenia rate of about 83%, and the febrile neutropenia rate was quite high as well, which was 8% in the cabazitaxel group, which led to this study, the Proselica study, comparing 2 dose levels. So the lower dose level met the non-inferiority endpoint in terms of overall survival. PSA response and time to PSA progression was better with the higher dose, but again at the expense of more adverse events. What does that all mean in practice? We would have a low threshold in our centre to use the lower dose level. If somebody is really fit and otherwise well, we'd go up to 25, but have a low threshold to go down to 20 if they were having problems. And the Vistana study did compare cabazitaxel versus docetaxel in chemo-naive metastatic setting, and cabazitaxel did not demonstrate superiority for overall survival. So docetaxel remains our first-line chemotherapy agent of choice, if not received in the hormone-sensitive setting. And as I said before, low threshold for the lower dose level of cabazitaxel. With chemotherapy, we do need 3 to 4 cycles before we can assess response, compared to the AR inhibitors where we can see a quite rapid decline in the PSA. So that's something that I would counsel patients about when I see them in clinic, because patients can get quite anxious if the PSA is not coming down quickly. At the moment, there is a lack of biomarker to predict those most likely to benefit from chemotherapy. And moving on to radium-223, Just touching on the mechanism of action, it's a short-range alpha emitter, works mostly in areas of increased bone turnover, so bone metastases where it causes double-stranded DNA breaks leading to tumour cell death. And the main evidence for radium-223 comes from the Alsimca trial, where it showed a survival benefit and prolonged time to first. And it continues to have a role in predominantly bone disease. And Dr. Jan, our previous speaker, looked at our own data in our centre, and in terms of overall survival as well as pain scores, our data is very much comparable to published trials. And hot on ESMO this week, targeted therapies and PARP inhibitors in particular. This was the PROfound trial presented at ESMO just this week with 256 patients who had disease progression on Enza-Abi, 2-to-1 randomization to olaparib versus another AR inhibitor, which was really a placebo arm. And patients with alterations in BRCA1, 2, and ATM did better in terms of overall survival, significantly better. So no doubt this will be filtering through clinical practice, and there's many more studies looking at combination PARP inhibitors as well. And finally, in terms of where we're going to, in terms of the future, there are some interesting studies currently recruiting and active. So PSMA 177 lutetium in metastatic castrate-resistant prostate cancer, which is being looked at with some promising initial results. Checkpoint inhibitors, I think it's already FDA licensed, pembrolizumab in mismatch repair tumours, and combination studies with PARP inhibitors as well. So in conclusion, in the UK, second-generation anti-androgens are our preferred first-line treatment option for most patients with metastatic castrate-resistant prostate cancer if they haven't received it in the hormone-sensitive setting. We would consider early chemotherapy in patients with particularly aggressive tumours, so patients with visceral mets, especially liver metastases, or those patients who become castrate-resistant within the first 12 months of diagnosis. There is no benefit going from one AR agent to the other, so that's something that we wouldn't be doing here. In terms of sequencing of treatment, all these drugs came in quite quickly in succession to each other, so there hasn't been the opportunity to do trials comparing them head to head. So I would say it's more of an individualized approach, taking into account the patient in front of you, the available evidence, and your own clinical judgment as well. The molecular understanding of metastatic CRPC continues to improve year on year, and no doubt this will lead to more advances in the future. Thank you very much for listening, and this beautiful picture of Newcastle is to remind me to thank my colleagues as well, Dr. Chandler and Dr. Jang, for their input in my talk today. Thank you.